Good afternoon, everybody. Welcome to the Lions Center. One of my favorite traditions here at SAEM started a while ago by the didactic here, so those of you know it well. He wanted to do this, but got overbooked. My name is Misha. I'm from the University of Pennsylvania, and this is going to be a really different session than most of the other sessions people have attended, and thank you for being here. The Lions Den is a really unique place where junior faculty, fellows, junior, really researchers to pitch ideas to our very fierce lions. Stay rich. And thank you, Lions, for being here. The idea of today is to get these pitches across to share ideas quickly, rapidly, and for very experienced researchers with long accolades that I will not take time going over to give feedback. Sometimes it may be a little harsh and a little fierce, but I believe in our lines today. So some ground rules for we have 5 amazing pitches to hear today, and so Lions, rules for you. No interrupting until we give you time. We would love your experience, your wisdom. Constructive advice and feedback is encouraged. In the past, some people have deviated from that. And offer just what you can. For our contestants, so it should be 5. You are looking for sponsorship, mentorship, guidance, because we know that research is really a team sport, and mentorship is really an important part of that. Each of you will have about 6 or 7 minutes. I will probably sit over here and pull up a little card, say 2 minutes or 1 minute, and then we'll cut you off, and we'll again throw you to the lines, so to speak, the lines. Do you have any questions, Lions? No. You guys are ready?
All right.
Ready. Somehow we got
roar. Yeah.
All right, I'm going to invite our first contestant, Emily. Emily, up here is a clicker, and I will sit right here.
We have to be able to see the presentation.
One quick thing, Anish. Is there a way for us to be able to
See the presentation?
Do you want us to sit there?
Yeah. Do you mind if we move over there?
Yeah.
This point of attention.
Thank you for saying that.
It's like a Disney ride.
It's really, over the years, I've had the fortune of moderating this. And we're either in the weirdest room or the biggest room. There one year we were literally land balls. So you're projecting out those giant shots. Okay, I think we're ready to go. Emily, the floor.
Is that a microphone?
I was just using my loud voice, but is there a microphone?
Here.
Yeah. Ready?
Hello. Is this okay?
Yeah.
All right. Okay. Hi, everyone. My name is Emily Ager. I'm a first-year fellow with the National Clinician Scholars Program at UCSF. Thank you all for having me today to give this presentation. The title of my proposed project is Adverse Mental Health Outcomes After Early Pregnancy Loss. Does initial care setting matter? For some background, early pregnancy loss or miscarriage is very common and occurs in approximately 1 in 5 pregnancies in the U.S. These visits account for almost 1 million annual ED visits, and this is because patients are often so early in pregnancy that they haven't yet established prenatal care, and so come to the ED for miscarriage care. Adverse mental health outcomes after early pregnancy loss are common, and up to 40% of patients will develop moderate or severe anxiety or depression, and up to 30% of patients will experience post-traumatic stress symptoms. For some patients, these symptoms resolved after a few months, but for some they can go on to last for years and can contribute to significant morbidity and impact future pregnancies. Unfortunately, there have been several qualitative studies across the last decade finding that emergency department patients seeking early pregnancy loss care report negative experiences and low satisfaction with their care. Common themes across these studies include a lack of clarity regarding the EPL diagnosis, perceived inefficient care in the ED, variable sensitivity and compassion among ED clinicians, and a chaotic healthcare experience. For example, here's a quote from one of these qualitative studies where a participant said, "I guess they didn't want to hurt my feelings or something. They didn't tell me verbally that I'm having a miscarriage. I just found out on my way home. It was on the paper, it was written on the paper." Here's a quote from another participant from another qualitative study who said, "It just took a while before I saw anyone. Not only did I have to wait before I was seen, I was in pain. I had no support, but then I had to go through 2 gynecological exams, which I thought was pretty unnecessary." This individual said, "I also specifically remember the short and rushed sharing of bad news as our physician stood on the opposite side of the room, cleaning the ultrasonography machine after it showed no cardiac activity." And finally, this participant from another qualitative study said, "And there was a woman in there that had a newborn baby, and that was hard. I know it's difficult in any space, but for someone who's now having to terminate a pregnancy, sitting next to someone who's just given birth to a baby." And although we know that EPL care in the emergency department is not meeting patients' needs, it's still unknown if these patient experiences with early pregnancy loss care in different clinical settings influence the risk of adverse mental health outcomes, including anxiety, depression, and PTSD. So with that motivation, the first aim of this study is to assess the association between the index EPL care setting, either the emergency department or ambulatory clinics, and EPL event characteristics with the occurrence of self-reported psychologic morbidity. And the second aim is to investigate how these patient experiences may mediate the relationship between the index EPL setting of care and subsequent risk of self-reported psychologic morbidity. So this will be a prospective cohort study among adult patients with an ED or ambulatory clinic visit, either with primary care or OBGYN clinic, for a new and confirmed early pregnancy loss event with several relevant exclusion criteria, which I haven't listed here. In terms of sampling and recruitment, eligible participants will be identified 1 to 2 weeks after their index EPL visit via a periodic EHR chart review. And then within 1 month after the index visit, they'll complete an EPL event characteristics survey, a patient experience survey, and then a psychometric measures survey. And then 3, 6, 9, and 12 months after their index visit, they will repeat the psychometric measure survey. The predictors for this study will be the EPL encounter location, either the ED or an ambulatory clinic, EPL event characteristics, including patient symptoms and their severity, their EPL management, and the gestational duration. And then their patient experience will be a predictor, and this will be measured by the CAPS survey, which is a commonly used survey to evaluate patients' experiences with healthcare settings and providers. The outcome will be the self-reported psychologic morbidity within 1 year after the EPL encounter, and this will be measured by 3 different surveys, including the revised impact of miscarriage scale, the hospital anxiety and depression scale, which is commonly used in miscarriage research, and the post-traumatic diagnostic scale for DSM-5, which is a frequently used tool to assess for PTSD. For the analysis, the first piece will include a simple comparison of the proportion of ED versus non-ED participants who meet criteria for anxiety, depression, and post-traumatic stress at each time point. And then the main piece of the analysis will be using generalized linear mixed effects models, given the clustered data and the repeated measures nature of the data, with the outcome of the risk of meeting screening criteria for PTSD, anxiety, and depression. And again, this will be using predictors including the EPL visit care setting, event characteristics, and then the care experience. And then I think an additional interesting piece is how the EPL care experience, like stated in the second aim, may mediate the relationship between the setting and the primary outcome. For example, among ED patients who have a negative experience, how do their mental health outcomes compare to patients in the ED who had positive experiences? And lastly, I think this project has the potential for many different impacts on the practice of medicine and policy relevant changes. The first is to develop ED-specific trauma-informed EPL clinical protocols so that we can implement the best practices in miscarriage care from other settings into the ED, as well as inform clinical guidelines for post-EPL follow-up and mental health screening, and translate this evidence into quality improvement and educational initiatives in several other specialties. Here are my references, and thank you all for your time and attention, and I'd be happy to take any questions.
Fantastic way to kick us off, Emily. That was great. Lions. So, we'd love to hear your questions, critiques, concerns. You may or may not want to look at them like a research proposal if you want to, but there's really no rules. So, except maybe trying to. So, feel free to whoever wants to go first.
Thanks, Nish. This was Dr. Agar. Is it Agar?
Agar.
I'm sorry. Dr. Agar, this was fantastic. Thank you for presenting it. I love the fact that you've reminded us like 17 times to be nice, so I promise. It's a really important study. Trauma-informed care is something that we all need to be building into our practice, and the fact that you're studying it in this way is fantastic. I do love the fact that you used a paper with one of the Lions' names on it. That was very sneaky. Way to try to bias the judges. I want to point out that we are resisting that bias, even though he was very happy that you used his and his wife's paper. I do worry a little bit. This is such a traumatic event, and full disclosure, my wife and I went through this a couple of times. I don't know that I'd want to think about it 6, 9, 12 months out. And if I did, I might want to just fill out the HAS survey, for example, instead of filling out 3 different surveys every 3 months for a year. Because honestly, we're trying again in a couple of months, and maybe it's happened again, and we don't want to remember the one from 6 months ago. That being said, I'm completely ignorant about the OB studies in this, and maybe that's just the way that they do this. It just seems to me like reliving that trauma every 3 months might be a little tough. But other than that, it's a wonderful study and a really important topic.
Thank you, Dr. Raja. Thank you, Dr. Agar, for presenting on a really important topic. And the strategy of citing a paper from one of the Lions, I fully endorse. So yes, I was an author, and I've been working in this space a little bit for a while, in conjunction with my wife and partner in a lot of things. But and so I think there's a lot to unpack here, and you're right. You're onto a bunch of things that are really encouraging and exciting, and present an opportunity for us to really move this field forward. Emergency department is messy in many ways, as we know, around how we take care of people with many different conditions. But early pregnancy loss, I think, is a place where we have a lot of work to do. I have a few specific questions and suggestions. As we all know, the initial presentation for an emergency department for possible EPL, early pregnancy loss, is a mixed bag of symptoms, and often we don't formally diagnose an EPL at that visit, whether it's a true index EPL visit or not. We may do an ultrasound, we usually do, but whether or not we're going to be diagnosing an EPL at that visit is may be determined retrospectively when we go back and look at the records, as you do, and identify that this was a non-viable pregnancy and their first presentation for pregnancy bleeding at 6 weeks, and no fetal heart tones were detected, but it was too early to determine if it was just too early. And I think you need to clarify that, because that's actually going to determine a lot of how patients experience that perspective, what kind of communication they got, how they felt afterwards. They may leave not knowing, and that could be worse, or it could be something that is a real true confounder in terms of how you think about the experience. The other part that it seems like you're missing is what kind of treatment they got for their EPL, unless I missed it, in terms of specifically whether they received medications for their early pregnancy loss. Was that administered in the emergency department? Will you be able to detect that? Whether they ended up in the OR or for a uterine evacuation, and when that happened, all has the potential to significantly confound your results, and you really need to be clearer about how you pursue that.
We can have one more Lions feedback. For the sake of
I can be brief.
Great, thank you.
Definitely got me at significance, got me at sort of the core hypothesis around how the emergency department setting influenced sort of downstream outcomes. I do wonder about the comparisons here between ED and ambulatory. I'm not sure those are exactly modifiable factors, and I wonder if the focus should be more on sort of what is modifiable within the ED encounter that could be interventions sort of down the line.
And Will, if you want to come on up as we transition to the very final, the Lions are roaring straight up.
Yeah, I worry that comparing between setting doesn't actually compare the type of care, which is the thing that you are most interested in. And so I would think about that exposure. I worry also about whether you're going to be able to get IRB approval to consent people 1 to 2 weeks after. And so you may want to think about the ascertainment a little bit more, about whether the patient experience survey is actually capturing the domains of patient experience that you think are relevant here. And finally, how you're going to handle people with baseline PTSD, anxiety, and depression in this cohort.
Great.
Thank you so much.
Hello, everybody. My name is Will Mundo. I'm currently a PGY3 at Denver Health, soon to be a chief resident next year. And prior to this, I completed an MPH in health systems management and policy. And my plan is to become an independent funded investigator in the future with the aim of improving the delivery of care for vulnerable patient populations, in particular those who face language barriers. And this is largely informed from me being a bilingual physician, but also my unique background from where I come from. And just to kind of preface this is like a 10,000-foot view, and my ask for the Lions is really just to kind of see if that vision is there. And I've thought about some of the methodology that we can get into afterwards, but I'd love to appreciate some feedback on that. So for some background, we know that, so for some backgrounds, we know that health inequities affect non-English speaking patients, in particular since they are a large proportion of the patient population. In 2022, there are actually 8.4% of all U.S. households prefer a language other than English. And this patient population is particularly vulnerable because they, not on top of facing the language barriers, they also face a lot of other social determinants of health that compound their outcomes, whether we're talking about socioeconomic status, racial and ethnic backgrounds, or even immigration background. And specifically, we know that these patients face treatment delays, medical errors, difficulties with understanding instructions, and also lower rates of diagnosis comprehension and higher rates of unscheduled healthcare utilization. That's why there's the importance of language justice, which essentially refers to the ability for patients to be able to understand in the language that they feel most comfortable and are able to understand. And we know that language services are an integral part of our healthcare system's ability to be able to provide equitable healthcare. And there's also a ton of evidence showing that it's been shown to save money, improve quality of care, and also improve outcomes. However, we know that there's some specific challenges in the ED that we face, in particular that all language services are not created equal, and there's varying quality of services depending on where you are and the resources that are available to you. And as a result, we often tend to use ad hoc solutions to address these issues. So therefore, we know that there's a need for innovative approaches to be able to address language equity. So in terms of how I'm going to do this research approach is pretty broad, but it's developed from the National Institute of Minority Health and Health Disparities. And essentially, this highlights all the different levels in which we can influence patient care. I think arguably one of the most important things about the ED is that we are the first point of contact for this patient population. And as a result of us being that first point of contact, it's also part of our responsibility to ensure that they stay in the healthcare system and that we ensure that they get the care that they need. And so in particular, where I'm hoping to focus on is improving the discharge process for our patients. Now, we know that effective discharge communication is vital for high quality ED care, and a lot of times they lack this understanding of their diagnosis. And a lot of best practices that are highlighted in the literature includes delivering structured content, verbal content that has audio instructions as well. It's tailored to the patient's language and reading level. But a lot of times, how many of you are doing this? Where you write your discharge instructions, you go to Google Translate, and then you copy it and paste it in your discharge instructions. Well, it turns out we know that is not safe, and machine translation continues to present a considerable risk factor or risk for inaccurate medical information that could potentially cause harm. And so overall, in terms of how I want to address this, I'm thinking about putting it into two phases. The first one would be through a phase with some training or pilot data where I would do a sequential exploratory mixed methods design, where I would do structured interviews with physicians who are having barriers and facilitators to provide language concordant discharge instructions, as well as focus groups with patients to be able to understand the impacts of these language discordant discharge instructions. And secondly, it would be, for the second aim would be, or the second phase, would be hopefully through a K award where we would implement technology to be able to improve discharge communication for patients. So kind of jumping a little bit more into the specifics for aim one specifically. Again, it would be to understand the facilitators and barriers to provide language concordant discharge instructions. And again, we'd use semi-structured interviews with stakeholders and then focus groups with patients. And for aim two, really, it'd be about understanding the impact of this problem. So aim one would be to describe the problem. Aim two would be to better communicate or understand the impact. And so we would do a prospective observational study for patients who have been discharged from the ED. The second phase would be piloting a mobile application that uses AI technology to provide language concordant audio and written discharge instructions through a multi-site randomized controlled trial, where essentially we would be looking at ED recidivism at 72 hours. And for secondary outcomes, we'd be looking at outpatient follow-up, prescription filling rates, and comprehension and quality of these discharge instructions. For the intervention, it'd be an AI-driven transcription analysis software that provides multilingual and audiovisual delivery information that provides personalized and clear communication, enhancing the accessibility and engagement of these instructions, and ultimately bridging the language and literacy gap. And so why me? Like I said, I got a master's in health systems management. I've demonstrated my research productivity. I've shown that I've been able to obtain sponsored research grants, and I've also have received some training to accomplish this. And so my ask for the Lions specifically would be to, one, hopefully get some mentorship in this area, not only as it pertains to research methods, but also like partnering with industries to be able to develop this technology, getting background information on protocol design and training, obviously funding, whether it's through support with writing grants, having a research infrastructure, a team that would be able to help me to accomplish this, and ultimately also finding additional partner sites to be able to pilot these different interventions at different areas. And with that, I'll leave it there. Thank you.
Excellent job, Will. Ryan, I'll throw it back to you all.
All right, maybe I'll get to start this time. Obviously, this is a topic that's very close to my heart, and so I'm really excited that you're doing this work. And I have a couple of quick thoughts. The first is really about the aims 1 and 2 that you presented from the proposed SAMF grant. And I worry a little bit that you are measuring disparities and inequities that we already know, rather than using the creativity that you have to start to think about the solutions to them, right? Because you could sit here and tell me what the barriers are to language concordant discharge instructions. There have been papers published on this. You know this, right? We don't have enough bilingual physicians or multilingual physicians, and we don't have good translation apps, right? And so doing a bunch of qualitative work to pull out something that you have seen in the literature and that you know, I worry is less a good use of your time and effort. And similarly, the data about language discordance and worse outcomes has been published across a wide range of conditions. And I worry that you're gonna get dinged for innovation if those are the only two things that you're doing in that grant. And the later work seemed much more creative, and it seems like maybe you could use the training grant to do feasibility and acceptability of that work, and then you can move it into the K once you've shown that this is something that actually can work, that is safe to deliver, that so you could start to do some of that early safety and acceptability testing in the career development, the foundation career development award. The last thing I will say is to be really thoughtful about 72-hour return visits as your primary outcome, because in some cases that's a marker of a failure of communication, but in some cases it's a marker of a successful communication, right? The kid didn't have appendicitis on this visit, but I said if he got right lower quadrant pain and couldn't walk, they should come back. They understood that and they came back. That 72-hour return visit is a win, not a lose, but you're gonna ding it. And it's very hard to get enough inter-rater reliability on that post hoc to figure it out. And so it's worth thinking ahead of time about what the model system would be that you're going to measure this against, so that you can actually measure the impact of your intervention successfully.
Awesome. That's great feedback. I think what I'd say is what I like about your story is there's, to me, like no better combination of a researcher coming to the table of a problem who has sort of the lived experience and the passion around the problem that you're trying to solve. So I love that in the story that you can provide. Definitely agree that there is a degree of specificity required here that Maggie you just did a great job of outlining around sort of how to sort of construct the scope and ambition in a way that gets you where you need to go.
I don't have too much to add. This is fantastic and important work. So congratulations for pursuing it. I would pose this question, thinking about maybe at a little bit of a high level. Your proposed solution that is in the bucket that Maggie pointed out is sort of further down the road for you is testing an AI solution to this this really important challenge. And I would question why that you need to think about why you and this work that you're going to do and how this is going to bring value or add to what is probably an inevitable force. AI is everywhere. Why Epic is almost certainly working on an AI solution. Google is probably getting safer by the day in terms of its AI. Why is this work that you're going to do, potentially not even for a few years if you're talking about a K award, how is that going to actually impact or improve what is almost certainly in force and already going down the pike already?
Thanks. I'll keep this brief because I know Dr. Muir's got to go. But Maggie, Keith, and Zach covered almost everything. The only last thing that I'd add from my notes is just the outcomes that you looked at even beyond 72 hours. I've got to tell you, I've got plenty of patients right now who understand English, are from the middle of Boston, white, and they still don't fill their medications and they still don't go to their outpatient follow-up. And so I think you're going to have to look a little bit more carefully at those outcomes just to find out how you can get rid of a lot of confounders that are already built into the very chaotic ED discharge process.
Jane, the floor is yours.
Thank you. I just want to start by saying that he coerced me into this. My name is Jane Muir. I'm an assistant professor in the Center for Health Outcomes and Policy Research at Penn Nursing in the Department of Emergency Medicine at Penn. And I'm pitching a research idea around hospital crowding. What's nursing got to do with it? So I'm sick of talking about ED boarding. And I'm a nurse, so I'm sick of talking about the chronic understaffing of nurses in hospitals. So what do you do when you're sick of stuff and you have a job in academia? You spend months to years researching it. And so that's what we're here to talk about, those topics. So all of these phrases or terms have two things in common. They're all strategies or interventions that have been tested with mixed effectiveness to address crowding, and they all are led by, tinkered by, piloted by, directed by nurses. But there's an overlooked question here in this crowding and nursing equation, and it's, first of all, do we even have enough nurses in hospitals to advance throughput? Do we even have enough nurses to pilot these initiatives in hospitals to address hospital crowding? And this is an important question because when we think about the whole patient throughput continuum, the Asplin input, throughput, output model, Nurses are at the entire range of that continuum. Nurses are the first hands to touch a patient when they come in through triage. They provide the majority of direct patient care for patients that are either boarding in the ED or those who are pure ED patients. They do the handoff to the inpatient nurses, and they're responsible for patient education and discharge and getting those patients out of the system. So this is an important oversight and gap in the ED crowding literature. So what do I mean when I talk about having enough nurses? I'm talking about the adequacy of nursing resources. Now, there's a lot of things that we can't control or modify with hospital crowding, but you can modify the extent to which hospitals have enough nursing resources. And what I mean by that are 4 things. The patient-to-nurse staffing ratio in hospitals, are nurses caring for too many patients at a time? The quality of the work environment, meaning the extent to which nurses have collegiality with their physician counterparts, autonomy in their workplace, input into decision-making in the hospital about workplace violence interventions or crowding interventions, and that they have supportive unit managers. The proportion of nurses with BSNs, many hospitals have incentives to get their nurses to reach a higher level of education, and also a higher nurse skill mix, meaning if you look at all the nurse or ancillary care staff in a hospital, are those majority registered nurses? So we have the highest extent of the license represented in our nursing care team. We have a gap here. We haven't evaluated this relationship between hospital nursing resources and ED crowding. But we've looked at other things. For over 2 decades in the Center for Health Outcomes and Policy Research, we've developed a line of inquiry around this relationship between hospital nursing resources and patient outcomes. And what we found is that when hospitals invest in more nursing resources, patients experience better outcomes. In a seminal article published by Linda Aiken in JAMA in 2002, the team found that each additional patient added to a nurse's workload is associated with 7% higher odds of patient death. This study was replicated to find increased hospital readmissions, prolonged length of stay. And we've replicated these studies with the other nursing resources, meaning higher proportions of BSN nurses, higher nurse skill mix. These are all things that, when modified, can lower patient mortality, improve patient satisfaction, decrease patient length of stay. Our team has done preliminary evidence looking at this relationship between hospital crowding and nursing resources using a survey of nurses who are direct informants to their care environment, meaning we survey nurses, we ask them, how many patients did you care for on your last shift, for example, or tell us about the quality of your work environment. Merging this with CMS compare data, we found that fewer patients leave without being seen in hospitals with better nurse work environments. So the left without being seen rates are significantly higher in hospitals with more favorable or in unfavorable environments compared to better work environments. And we've also found that patients board for 20 minutes less in hospitals where nurses care for fewer patients at a time. These studies are preliminary data conducted in hospitals in fewer states, two states. So my goal is to do a larger study. There are no large multi-state, multi-hospital evaluations of this relationship between hospital nursing resources and hospital crowding. I hypothesize that hospitals with favorable nursing resources will experience less hospital crowding. Where nurses, for example, are able to care for fewer patients at a time, they could potentially attend to their patients more readily, advance high-quality patient education, move patients through the system more efficiently than when they're overburdened with a high workload. What do I bring to the table here? I have data on nursing resources from a large survey of nurses called the Nurses for All 2024 survey data, and we're collecting data right now for the 2025-2026 survey data. We have data from 100,000 nurses in 1,300 hospitals in 10 US states. I bring expertise in nursing workforce, health services research, and health policy. What I need is better boarding data than CMS compare. I need funding, don't we all? And I need physician allies to mentor and collaborate on this project, because nurses are not at the table with this conversation. There's a lot of literature out there about we don't have enough beds. Are we talking about nurses, staffed beds, or are we talking about the physical bed? We need nursing in that conversation. So looking for physician allies with this research opportunity. Thanks for the opportunity, Anish. And I'm happy to be shredded by the lions.
Thanks, Jane. So what I really like about research at times is how people can take sort of one perspective and shift the frame of reference and open up sort of a new window of inquiry and innovation. I really like what you did in the setup around, hey, we think it's all these X problems with crowding, but honestly, it's also a nursing problem. How do we begin to sort of understand those dynamics? So I really like that narrative and that story. I think certainly some things to dig into, as you approach this in a very, sounds like kind of quantitative way. And I certainly appreciate, it looks like a lot of preliminary work, on this topic is like, what is the specificity around kind of the causal pathways that connect sort of nursing to these problems around boarding and length of stay, being kind of very specific about what the outcomes are going to be, sort of around trying to connect those dots. And, of course, what are the data sources that allow the kind of granularity that you're going to need to begin to sort of explain those relationships. But I really like the way you've started and what story you're able to tell here.
Thanks.
Dr. Muir, that was great. Thank you. Just to follow up on what Keith had to say, I think thinking about causality is important as you really dig into this. And I'd love to see DAG, a dicyclic, acyclic graph, where you basically start to try to think about mapping out both directionality, confounders, how potential effect modifiers in this really complex relationship between staffing and boarding. What I want to know, and this you may not be able to get from your survey data, is, as we all know, a nurse in the emergency department is maybe different than a nurse in the ICU, maybe different than a nurse on the floor. And they all, in different ways, might impact boarding in the emergency department. And so where do we put that extra nurse if we get additional resources? Is there a place that may actually allow for reduced boarding? And specifically, are there unintended consequences? We've talked about this before. If a staffing ratio is keeping on the floor is keeping a patient in the emergency department from actually going upstairs, maybe that's an inefficient way of thinking about this problem, particularly if it's not being applied uniformly, a staffing ratio rule across the house.
Absolutely.
So these are great questions. I'm really excited to see you develop them. I'm excited to maybe have an opportunity to partner with you on this.
Awesome. I know where you work, so great.
This is great, Dr. Muir. So just a couple of things to add on to what was already said. First of all, I'm the husband of a nurse researcher, and so this is near and dear to my heart. Plus, we all are dealing with a ton of boarding, and so we're looking for ways to ameliorate that. Is great. One of the things that I have, the only concern I have so far is just how to translate this. In the graph you showed about ED length of or ED left without being seen rates, there was this really qualitative other factor, which was, is your working environment, I think it was good, bad, or horrible. I can't remember exactly what it was. And so as we translate these, I'd love to know how we can take our emergency department, and not ours, because Maggie and I work in the world's best emergency department, and help translate it from going from horrible to good. And so maybe there's more quantitative or objective factors that are factored into that. But right now, the outcomes you're showing are relative, or it seems subjective. And so if you're going to translate this into something that hospitals can actually make changes with, I'd love to see something more granular and seemingly quantitative or objective.
Thank you. Thank you.
And
all.
also would love to work with you as well.
Oh, he has a comment.
No.
Oh, for me, yes,
Sorry,
please.
super interesting work. Just 3 quick things. I really liked that you were specific about the domains of the sort of nursing characteristics that matter. I think when you're presenting this work in a grant, it'll be really important to justify why those 4 domains and
Yes.
not like the 5th thing that your reviewer just thought of while they were reading it, and that's going to be really important. The other thing is, we've all talked about confounding here, but when you talk about the nurse experience impacting left without being seen, I'm thinking about, is that hospital just more functional on a whole bunch of other metrics, and how are you going to possibly measure all of those metrics to pull out the fact that the nursing experience is the key piece of that? And as you're thinking about methodologically how to do that, maybe you already know how to do this, but I would think about more complicated causal models, potentially thinking about something called coincidence analysis that lets you look at complex systems and what are the characteristics that are required for those to be successful, because that's the kind of thing that'll let you model this type of pathway.
Thank you. Really helpful feedback.
Lions, you guys are crushing it. It's amazing. The energy.
Hi, everyone. Thanks for having me. Thanks for being here. I'm Joshua Kimbrell. I'm a first-year medical student at Albert Einstein College of Medicine.
That's why I reminded you.
Thank you. we're going to talk we're going to talk about TCP in the emergency department. No financial disclosures. So transcutaneous pacing, let's get right into it. The American Heart Association has a Class 2B very low certainty of evidence recommendation for TCP, only as a temporizing measure until you get transvenous pacing or the bradycardia resolves spontaneously. I'm going to describe a little bit about why that evidence is so uncertain and talk about some ways we can try to fix it. So early 1950s, Paul Zoll says, hey, I have this really cool machine. We can use it on ventricular standstill. We can put pads anterior, posterior, crank up a really high current, and we can get the heartbeat to go when we have this ventricular standstill in these sinus node dysfunction patients. In the EM literature, it took about 30 years. We started to have some EM researchers that said, hey, we have these case series, these small retrospective cohort studies showing that this can be done in the ED for our brady asystolic cardiac arrest patients, which today I think we'd call an asystole cardiac arrest or PA arrest. And then we had 2 prospective randomized control trials from the pre-hospital literature from Hedges and Barthel. These were pre-hospital paramedic-led trials on mostly cardiac arrest patients. So these were, again, asystolic or PEA arrest. And they put anterior posterior pad placement. They cranked it up to the highest current, and they never had ECG interpretation. So this is far different from what we have today. More recently, at the turn of the millennium, 1999-2005, some ED studies looked at ultrasound for confirming capture. A systematic review went in and said, hey, there's actually no evidence to do this in cardiac arrest. That's now a class 3 recommendation. We said that causes harm. We don't do it. But based on a sub-analysis on some of these trials, we think that it might be feasible. So we're going to give it a class 2B recommendation and just kind of go wild with that. Laurie Morrison's group in Canada did feasibility pilot comparing transcutaneous pacing versus dopamine performed by paramedics, specifically for symptomatic bradycardia. They found that it was a feasible trial. They did not find a signal for the direction, and they said this needs a multi-center study, and a multi-center study never got done. Speed up to the last few years. You have a group in University of Maryland, Moyetti et al. Did a study in the EP lab. They showed that post-cardioversion, when they took patients and randomized them to AP or AL pad placement, that anterior-posterior was better, which kind of aligns with our earlier literature. And then just a couple of years ago, some Greek electrophysiology researchers showed how with TCP you have this huge electrical artifact that kind of jumps off the page that makes interpretation really difficult. This was similarly talked about in like the kind of FOMED blogosphere, at least in the EMS world, for several years leading up to this, where they called this false electrical capture. So it was this kind of artifact from the pacer spike that's kind of masquerading as capture. And so just last year, there was a study published using pre-hospital transcutaneous pacing in the ESO Data Collaborative over a few years. And what they actually found is for patients that had TCP that weren't in cardiac arrest originally, 1 in 5 ended up having a cardiac arrest. And of anybody that received TCP, 2/3 of those either died during admission or were discharged to hospice. And my question is whether TCP could be causing these poor outcomes. I think obviously this is a very sick population, so trying to tease this out is going to take some work. We did a small study in our EMS department in Queens, New York, where we looked at 23 patients with transcutaneous pacing over 2 years. And basically our question was, if we went back and visualized the ECG from the start to the finish, how often each pacer spike had wide QRS with a T wave with each pacer spike that was compatible with capture, sustained from the highest current to the end of the case. Either they had to turn it off or they had to arrive with transfer of care. And so this is a quick just visualization of what that looks like. On the top, you can see this underlying junctional rhythm. They turn the pacer on, and you can see, I highlighted it here in the circle that we published in our paper. As this gets bigger with the current getting higher, it looks more and more like it could be a complex, especially in a very stressful situation. And so intermixed with these underlying beats, it can be really confusing. I showed an example of actually true capture with a synchronous clef wave on the bottom. So we're kind of left with quite a few research questions, but 2 that I think we could answer. So 1, how frequent is unrecognized false electrical capture in the emergency department? This really hasn't been looked at in the emergency department setting. It is an infrequent procedure, especially in our highly academic centers that have more resources. But I'm concerned that in the less resource places that might rely on this, we might have this more often. Additionally, I don't really have any idea from this retrospective study or from any of the other work how often true electrical capture on the ECG is actually associated with pulsatility, right? So whether that's visualized by ultrasound or by arterial line waveform, we don't really know how often it actually gets to pulse contraction, heart contraction. So our proposal is a retrospective cohort study to start. And so this would be at the Montefiore Network Emergency Department going back to May 2021. So we have Zoll defibrillator files, thankfully, for another clinical trial we're working on. And we want to identify transcutaneous pacing patients by their billing code, by their CPT code, and look them up through the EHR and link them with the monitor files that we have recorded. And in order to qualify, you both need to have the billing code and you need to have TCP visualized on the defibrillator file or the cardiac monitor file for at least 60 seconds. So our exposure here, or our primary outcome and then our exposure for a second outcome is the presence of electrical capture for at least 60 seconds until the duration of the case. And so this is something that takes a little bit of time. This is definitely susceptible to measurement bias. And so this will involve training, IRR, and blinded review. And then our secondary outcome is survival to discharge, an objective patient-centric metric. So again, primary analysis is just a descriptive analysis to look at the proportion of patients and describing the cohort that had sustained true electrical capture and those that did not. And then for a secondary analysis, a descriptive analysis comparing survival to discharge and sustained true electrical capture to those without it. I don't think we'll have enough of a sample to kind of try to look to create a DAG and try to account for all the possible influences on that causal pathway. So request for the Lions here. Feedback for the methodology of this study, longitudinal mentorship going forward, and potentially in the future obtaining seed funding for a prospective study. Thank you.
First of all, congratulations being first year medical student presenting such a nuanced and sophisticated project. Really impressive and important. It convinced me that it's an important question. The question that I have relates to your secondary. Well, first of all, I'm not sure you're going to be able to. As you point out, this is a rare occurrence, and the retrospective chart review be able to identify all the data elements that you need, particularly related to capture. And I'm just wondering, particularly related to your secondary outcome, and also potentially your primary outcome, if there are proxies for capture, including like blood pressure or something like that, as opposed to looking for survival, which is unlikely in somebody who's in true arrest or somebody who is super sick. If there are ways that you can get creative in thinking about capture, given that you've laid out an articulate argument that we may be identifying false capture, at least through the medical record, it may be worthwhile for you to start digging into some of these charts and just seeing what's there as like a test case for you to say what's in there, what is to me indicative of what may actually be real and what could be false, and which are the kind of data that I'm going to need to pull either from EMRs or other data sets as I start to explore this topic more.
Thank you.
Yeah, I mean, first of all, showing up is all you needed to do. Great job, Josh, as a first-year med student. Just a couple of thoughts from me. So I think entering into this, you just have to be very realistic about the ambition around what kind of learning you're going to derive from a retrospective cohort study with probably low sample size, and what kind of learning you're going to garner out of that based on probably a whole lot of investment in the work. And so very careful thought, I think, about what those next steps might look like that tie back to the work that you've got here. And you started to talk about some of those things, but I think before entering a whole lot of work, I think you need to be careful about what those next steps look like.
Yeah, I think you've almost got two questions here, right? One is, does transcutaneous pacing kill people? And the other is, do we fail to recognize when it's not going well? And I would encourage you to move to question 2 instead of question 1, because question 1 requires large sample sizes and a whole lot of work, and that's going to be really hard to do right now, particularly for a rare procedure. But question 2, you could actually do with like a simulation study where you give people a bunch of tracings that either do or do not show false capture, and you could say like, attendings are really bad at it, fourth-year residents are really good at it, right? Whatever the thing is, and start to show that this is an educational problem that we need to address. And that's something really feasible that you could do right now to get people thinking about the problem. And then you wait until you have access to a larger cohort to go after question number 1.
Thank you.
Great. We have one more presenter. Keisha, I'm going to close this out. Thank you.
Can I just press forward here? Oh, great, yeah. Hi, I'm Hashim Zikri. I'm a second-year fellow right now at the National Clinical Scholars Program at UCLA. I have no disclosures. I do have a mentor at Penn who definitely did not properly prepare me for this talk, and he's also a moderator here, but failed to show up for that as well. But he's the best mentor ever. So one piece of feedback that I've gotten a lot is in some of these big ideas. I'm very interested in how we can better use the emergency department as a center for population health and move beyond the emergency department as just a bad outcome within the world of population health and start to leverage it as an opportunity instead. Right now, a lot of my work focused on innovative alternatives to acute care and how to evaluate them. This is a very different project that's in its very, very early ideas of submitting it as an institutional K at my current institution. And I'm very interested in feedback at all stages about how to craft the question and about the methodology and thoughts around it. This is very early. A lot of times, we have a patient that will come in with an ankle sprain. Somebody comes in and you put them through the Ottawa ankle rules and you decide that you need imaging or you don't need imaging. And during this process, they'll get a finger stick while in the emergency department. That finger stick will come back at about 333, or it's elevated a lot of times. And at least for me, I don't really know what to do with this. Many times, patients are hyperglycemic, and we have no actionable way to quantify what that really means. Is this clinically meaningful hyperglycemia? What are we going to do with this? Is there a better way to get this person plugged into care? And does this individual reading even mean anything? If somebody eats a ice cream sandwich before they come to the emergency department and happen to have this glucose reading, does that mean anything? I think diabetes and this use case is a very interesting insight into how patients, in a patient-centric way, can better navigate health systems. Is the right answer for this patient to optimize their transitions of care? Is it to create an access bridge from the emergency department to get them plugged into a PCP's office? Or can we start to treat diabetes sometimes from the emergency department? The first aim of this proposed project would be to quantify the burden of undiagnosed or untreated diabetes among ED patients with hyperglycemia. So using data at my health system, UCLA, along with a partnered FQHC, Venice Family Clinic, I'm interested in looking at the electronic medical record for patients who come to UCLA and are found to have a glucose reading that's above 300, who have an assigned impaneled primary care provider. I'm interested in first seeing, do these patients even have a hemoglobin A1C on file? If they have a hemoglobin A1C on file, we can look to see the association between that point of care glucose reading and the hemoglobin A1C to see how often it's clinically relevant. For those without a recorded hemoglobin A1C, I think we can all agree that somebody with a single glucose reading above 300, and endocrinology literature supports this, should get an A1C over the next year. I'm interested in AIM 2, or AIM 1B, to look at when they first start to get that A1C. Part 2 of this project would be beefing up my qualitative skills to begin to look at patient-centered ways to ask these questions in the emergency department. We would conduct semi-structured interviews with the patients who are getting discharged in order to ask them about the clarity and feasibility of follow-up instructions from the ED, as well as their interest in starting diabetes treatment from the emergency department. We would also look into the acceptability of initiating chronic care interventions such as metformin, or what patient thoughts would be on starting that from the ED and when they did end up starting it. Lastly, we would pilot the feasibility at our health system, which we do not have this, of a reflex hemoglobin A1C for patients who are found to be hyperglycemic. This in and of itself is not a novel idea, and I think a lot of your institutions might do this for people who have hyperglycemia readings in the ED and get a BMP. But getting this hemoglobin A1C data would start to allow us to pilot other novel interventions of looking at when these patients can follow up and start to investigate some studies on when we might begin to start disease-modifying agents from the emergency department. I have way too many people to thank, and I'm so impressed with everybody that's spoken already, and thank you guys for the opportunity to present here. I appreciate it.
First of all, Dr. Zickery, wow, that got really loud all of a sudden. I'm so sorry that you got abandoned by your mentor. That's horrible. But glad you're here. All right, so I'm sure we all have great feedback. I'll start. So first of all, really important topic, population health and emergency department, especially preventative in the way that you're trying to do it is great. It's 2025. You don't need a hemoglobin A1C. You don't need a single glucose measurement. Get CGMs. We're starting to use continuous glucose monitors for something very similar, especially on the inpatient side. There are studies already studying those. If you're going to start somebody on metformin, if you're going to try to get them into treatment, slap a CGM on them. And you get away from the problem of trying to measure a hemoglobin A1C that may or may not correlate to a one-time glucose measurement. I think we're going to start seeing studies in this space that use continuous glucose monitors as the intervention. And if you can get ahead of that, go that way instead of a single glucose measurement.
Thank you.
So I think where I'd start is I definitely agree that like we see this all the time, and we have, I think, a lot of uncertainty. I certainly do about what to do about it when I encounter this problem. In part because what I think is missing here in the story is I have a lot of uncertainty about to what extent I can control some outcome down the line. In those types of patients where we're not talking about like the glucose being the sole problem that we're trying to fix in the emergency department, it's a sidebar problem. I assume that's kind of the framing that we're talking about here. And so I think some of the work that I didn't see talked about, but I think needs to be done is linking kind of these occurrences with some of the longitudinal, perhaps harms that you're postulating are occurring. And so I think some of that work should be done as well.
Thank you.
Yeah, just two quick things. One is I noticed that having a PCP was an eligibility criteria for your study, and I really worry about both the scientific and equity implications of that criteria, because a lot of the people who are not getting successfully linked to care probably are the same people who don't have a PCP, who are the people that ED is going to need to care for. And so I would be really thoughtful about whether that's actually the inclusion criteria you want. And it's definitely going to limit the diversity of your sample for sure. And then the other thing, just be thoughtful if you are going to go with the A1C, that you're thinking about the timing of that in relevance to the glucose measurement in the ED, because it is possible that it was normal and then would not have been normal if it was checked closer to the ED visit. And so I would just encourage you to think about a broader sample size and then being a little bit thoughtful about the timing.
Awesome, great, important study. I love that you started with this sort of big idea slide/framework, and it strikes me that the big idea potentially, and you probably have thought about this, is really how emergency departments potentially screen, identify for, and treat chronic or acute on chronic disease, right? And this one of the reasons I think this is exciting is because it feeds into potentially a whole body of work that really focuses on thinking about how we historically have not dipped our toe into this realm, and more I think we are the folks who are starting metformin or antihypertensives or buprenorphine or all of these diseases and medications that are often thought of as potentially outpatient, but since technically we are part of that continuum, it is an important place for us to at least explore, particularly some of the the philosophical questions about what's the right place, right time to think about this. So just wanted to sort of congratulate you and also ask you to think about sort of all the other pieces that potentially fit into this, because it's potentially an entire body and career that you've laid out right here.
Thank you.